warahmatullahi wabarakatuh. This is Dr. Muna Al-Magasla, a family and geriatric physician in John Hopkins Aramco, located in Ras Al Noor. Today, I will talk about care of beloved elderly with a brief introduction of geriatric medicine. We are aging population. Most of us are getting old, and and the percentage of elderly are increasing worldwide. It's become increasingly important for us as caregiver and health worker to know how to deal with the elderly and help them to age well and, and preserving their independency and purpose in life. In Saudi Arabia, from 1950 to 2005, the percentage of population of people above 65 frequent between 2.6 to 3.6 and stood stable at 3% in 2010. It projected that it will start to trend more after 2015 with the pace of increasing escalating after 2025 reaching to 18.4% in the year of 2050. These data are from United Nations, as I can show you in the next table. As we see in this table, that our population above 65 currently in 2020 at 4%. However, it will increase during the next few years to reach, for example, to 12.1 in 2040. And as I mentioned before, it may reach to 18.4 in 2050. The current life expectancy in Saudi Arabia in 2021 is 75.3 years, with increase 0.21 from last year. This data is not including the COVID pandemic. Life expectancy at birth in Saudi Arabia gained 9.4 from the periods in 1980 to 80 and 1985 to the period 2005 to 2010, increasing the age from 64.9 to 74.3 years old. It was projected that it will reach to 81.8 years old in the period of 2045 to 2050. This is from United Nations. As you can see, there's a project that during the few years, the age acceptance life expectancy will increase in Saudi Arabia. This table will show the life expectancy in Saudi Arabia comparing male to female. If you notice here, for example, in 2020 to 2025, the life expectancy in the male will reach to 75.9 and female 79.4. Also, worldwide, actually, the aging are increasing. Some of Shersel mentioned that in Europe and Japan, there is annual increase to the patient who are above 100 years old by 7%. And as you can see in the diagram here, that in the most developed countries, in 2010, the age can reach near 80s. There's some aging physiological changes and elderly as we get older, there's changes occur in all the body system. These physiological changes make the presentation of illness or disease different than younger patient. The hallmark of aging is decreased ability to respond to stress, and that response to stress usually present as the presentation of the disease more vague and different than younger individual. For example, young individuals, when they have inflammation of the appendicitis, usually they have a pain in the right lower abdominal area. They have fever, nausea, and maybe vomiting. You can see increase in white blood cells in the lab test. However, in the elderly, usually when they have appendicitis, the response to the disease is different. They will have usually vague abdominal pain with tenderness. They may have acute confusion stasis, what we call delirium. That means they are confused. They may not have increased in white blood cells. They may not have fever. As I mentioned, the response are different from older to younger generation. Example for some of the physical symptoms that happen in elderly, the heart, for example, the heart, the cardiovascular system of the heart, there's a progressive loss of heart cell and stiffness of the last vessel and heart muscle. These changes can result on impaired of the relaxation of the heart, which lead to increase of the fluid in the lower limb, or even difficulty in breathing. In women, when we reach menopause, there is hormonal changes and lack of estrogen that can cause some changes in our appearance or even in our private area. Respiratory, the lung, for example, there's decrease in muscle mass and the strength of the chest wall that may impair the cough mechanism and that may increase the risk of having lung infection or pneumonia because of the impairment of this function. That's why most of the elderly have common diseases that can happen to them because of these physical changes. Some of them, like hypertension, diabetes, increase of cholesterol or hyperlipidemia or dyslipidemia, hypothyroidism. That means the thyroid gland dysfunction, constipation, benign prostatic hyperplasia, cataract, osteoarthritis, and insomnia. These are common diseases in elderly. I will not discuss them in details. We'll discuss in details or briefly about geriatric syndrome. Geriatric syndrome, usually, these are illnesses that are unique and elderly. Doesn't mean that younger population will not have them, but it's more unique to the elderly patient. For example, depression, delirium, which mean acute confusion stages, dementia, fall, malnutrition, polypharmacy, urinary incontinence, dizziness, osteoporosis, pressure ulcer, hearing impairment, and visual impairment. I will talk briefly about some of them. We'll talk first about dementia. Dementia is cognitive impairment. Dementia is an illness that can happen to elderly that cause memory loss with loss of their function or independence. Once the patient have loss of memory only without losing any function, we call it mild cognitive impairment. We don't call it dementia. However, when the loss of memory is combined with loss of the function or loss of their independent life, we call it dementia. Most common type of dementia in our population is Alzheimer and vascular dementia. Alzheimer is well known. It's Alzheimer that usually can have some genetic character because of the aging. However, vascular dementia that I want to talk more, vascular dementia does mean that the patient, because of some of the diseases, have multiple infarct in their brain or small impact in their brain that cause them dementia. Usually, patient when they think about when the patient think about not a stroke, they think about the weakness, drooling, and ability to talk. However, some patients suffer from small stroke in small area in the brain that doesn't cause weakness in the muscle. However, it can cause memory loss and loss of their dependence. So far, unfortunately, we don't have 100% cure for dementia, both vascular or Alzheimer. There's a new medication that is a promising FDA approved that can help Alzheimer disease. However, the medication is just approved in this year, 2021. We need more information about it to see if it will help delay the process, or even cure Alzheimer's disease. We have some medication are FDA approved for patients with Alzheimer's dementia and patients with vascular dementia that can reduce the progress of Alzheimer's or vascular dementia, may improve the function of the patient. However, they have a lot of side effects. So each individual need to discuss with their primary care or geriatrician if it appropriate for their beloved one to receive this medication. There is some prevention for Alzheimer. Sorry, for a vascular dementia. The main preventive for vascular dementia is controlled diabetes and hypertension, as they are the most common causes for vascular diseases like heart disease, heart attack, or stroke, even vascular dementia. So a patient who suffers from diabetes and hypertension, he need to follow up with his doctor to control the disease with the help with the medication and lifestyle changes. So far, evidence-based medicine approved that health lifestyle, healthy diet, Mediterranean diet or Dutch diet, physical activities, being active every day, walking, moving around, and tobacco cessation is one of these are most prevent sorry, these changes will prevent dementia disease. There's some evidence about vitamin E that taking vitamin E may help to prevent dementia or help dementia. There's some evidence that wearing hearing aid will help the elderly to be not socially isolated, and it may help dementia or prevent dementia. Also, there's also some herbs. However, as I mentioned, the evidence-based medicine so far approved mainly the health lifestyle, diet and exercises with tobacco cessation and control of chronic diseases. There are some reversible causes of cognitive impairment. They can mask dementia. For example, depression, if the elderly beloved one has depression, it can be presented by memory loss and lose care of himself. So we maybe the people think that he has dementia. However, if he came to the doctor and the doctor take full history and examination, once we diagnose him with depression and give the medication for him, he may have his memory back, his self-care back, and independency back. Some diseases, for example, like hypothyroidism, may also cause memory loss. So once they have any concern about memory, one of the workup we do usually seek the thyroid function. If the patient suffer from hypothyroidism, once we treat them, his memory come back. Polypharmacy. Polypharmacy usually if the patient on multiple medication or the patient take a medication is inappropriate for his age can cause cognitive impairment and memory loss. Once he go to his doctor, the doctor usually review his medication and see if there are any problem with any medication, he can stop it. Usually, these medication, for example, antihistamine, the first generation, usually cause impairment of memory. Once we stop it, it can come back to his normal baseline. Normal Vascular hydrocephalus is a condition that increases fluid in the brain. These conditions usually have three triad or special symptoms, we call them, that the patient have walking problem, urinary incontinence, that means loss of urine, control of the urine, and memory loss. Usually when the patient present with these three symptoms, usually the doctor do a CT brain to make sure if he has this disease. Once we have the evidence that he has normal Vascular hydrocephalus by CT, we refer this patient to the brain surgeon to do a simple procedure that will restore the patient function and memory. Delirium, we'll talk later on about delirium, acute confusion status in detail, so I will not discuss about it now. Vitamin B12 deficiency also can be presented with memory loss. So once we do a test for the patient and we found he has vitamin B12 deficiency, usually once we replace the vitamin B12, the memory can go back to normal. Polypharmacy. Polypharmacy, that means multiple medication, more than five medication. Usually elderly patient who have diabetes, hyperlipidemia, hypertension, most likely he will have five medication or more. These patients who have five medication or more, we need to review the medication annually and make sure there is no drug interaction, there is no side effect from this medication. More than five medications usually increase the risk of side effect, disability, and falls for the patient. And it can also lead to medication non-adherence. That means the patient feel bored or too tired to take all his medication, and at the same time decrease quality of life. So usually sometimes we cannot decrease the number of medication. However, reviewing the medication is really important to avoid any drug interaction and at the same time to avoid giving the patient any inappropriate medication that is not appropriate for his age. So one of the solutions that usually I always ask my patient to do is to bring the medication back. All the medication they are taking at home, even the one I prescribe, all medication they take it over counter from outside. So once the patient brings his medication, we review them, make sure that the patient take the same doses, the right doses, that the patient take this as a right amount, and that the patient doesn't have any inappropriate medication. Unfortunately, because we have a lot of brands, medication, and names, and sometimes even the same company, our same healthcare change the brand. Sometimes patients can get confused and take double dose from the same medication, thinking they are different medication, which lead to more side effect and drug-to-drug interaction. So it's really important for the patient, especially elderly, to bring their back at least once a year for their MD doctor to review the medication. Also, the patient shouldn't be feel shy to ask the doctor, should I be in this medication? Do I need to be in this medication? Is there any problem to having this new medicine to all my old medicine? This will increase the awareness of the doctor and the patient itself to review the medication to make sure again that this medication is appropriate and the patient need it and they don't have drug-to-drug interaction. One of the problems that we face that some of the patients go to multiple doctors and multiple doctors describe different medication. Sometime, unfortunately, it can have patient can have the same medication twice from Dr. A and Dr. B. Sometimes also the patient can have the same family, not necessarily the same medication, but same family from Dr. A and Dr. B, which means that he taking double dose of this medication, which can lead to interaction and side effects, severe side effects. I have example, for example, metformin. Metformin is common medication that we like to give for diabetes because of the benefit. They have different brands. I don't know how many brands in the market for that metformin, but I have a patient who has he has confusion and become more tired and restless. When we review the medication, we notice that he taken double dose of the metformin because they are different two brands. So it's really important to bring the medication back to review it with your doctor. We'll talk now about delirium or acute confusion stasis. Acute confusion stasis does mean that the person have lower ability to think clearly, focus, or stay alert. Okay, acute confusion stasis usually resulted on real illness, organic illness, or disease. For example, the patient may present with confusion, yelling, screaming, or sleeping too much. However, when we emphasize more, he may have ear infection. He could have a lung infection. He could have even a fracture. I will give you an example. Sometimes patient, the demented patient, the patient have dementia, usually his baseline of alertness is different. Okay, so the most important that the patient, the caregiver know the baseline of his beloved elderly. For example, if the beloved elderly have a habit that he wake up at 10 o'clock, even if he demented, eat breakfast, talk a little bit with them, then space out. Then again, he sleep again, take a nap, small nap at 2 o'clock, and work away again at 3 o'clock to eat, talk with the family, space out, then sleep again at 7 o'clock for half an hour, and then stay awake until 12 to sleep at his bedtime. Imagine this elderly, same elderly, is starting to sleep most of the day. That means he doesn't wake up at 10 o'clock to eat breakfast. He doesn't wake up at 2 o'clock to eat breakfast. That means it's different from his baseline. Once he's different from his baseline, the caregiver need to ask himself that most likely this is a disease, that he has an illness or disease. So he need to take him to emergency doctor to see him and do full investigation to see what's going on. Sometimes this is what we call it usually we call it hypoactive confusion. That means low activity. Sometimes patients with acute confusion status have hyperactive, more activity with the confusion. That means he's yelling, screaming, swearing, or throwing the stuff around. And this is not normal behavior for the elderly. That means also, again, we need to investigate to make sure he doesn't have any illness. For one of the example, for example, about it, sometimes the caregiver doesn't notice that the elderly fall down. He fall down and walk again without any issue. Later on in that day, he starts having confusion, talking nonsense. At that time, he could have even fracture from the small fall. If he took it to the doctor will examine him fully, make some lab tests, make some imaging if he needed, and it can also diagnose with the fracture. Sometimes can even diagnose stroke with delirium or acute confusion stasis, or even heart attack. So it's really important that once elderly have change in his mental status, that the change of mental status is new, that it need to be taken to the doctor to make sure is it dementia or acute confusion status. And usually, as I mentioned before, the acute confusion status is a sign of illness, organic or pathological illness that should be treated. Urinary incontinence. Urinary incontinence, it's not a normal aging change. It's not normal for elderly to have urinary incontinence. That means lose control of urine. Usually it have causes, and the most of the causes sometimes treatable or controllable. We can control it. Urinary incontinence can cause disability, depression, and social isolation in elderly. Unfortunately, elderly, when they have urinary incontinence, they feel ashamed and embarrassed to talk forward about it. Usually, they don't tell the doctor that they have urinary incontinence. So usually, the doctor at least once a year asks the elderly if they have any urinary incontinence. However, if you know that if the patient have urinary incontinence, we need to do a full examination for the patient and full history and examination, and try to find the causes. Sometimes in male elderly, the causes can be benign prostatic hyperplasia. And once we treat the prostatic hyperplasia, his urinary incontinence could be resolved completely, or at least controllable to be limited to a few times a month instead of daily accidents. The other also in the female, because we deliver and have babies. Okay, so sometimes because of the delivery and babies, we have weakened vaginal wall and uterine polyps. So it can be treatable and can be manageable. Okay, sometimes some patients have constipation, and constipation can worsening or cause urinary incontinence. So once we treat constipation, it can improve the symptoms or resolve the symptom. So there's different causes of urinary incontinence. That's why the patient should inform his doctor, and the doctor usually do a full examination and history and do what is necessary and manage the patient. Osteoporosis. Osteoporosis, that means weak bone, that the bone is fragile. And usually we need to discover this issue before the patient have a fracture, because these patients who has osteoporosis, any low impact fall or trauma can cause major fracture for them. For example, if younger patient fall down from the bed, he may have only little bit muscle pain or aches. However, elderly, if he fall from the bed to the floor, he may have hip fracture. So how to prevent this issue? Usually, by expert opinion in Saudi Arabia, we should screen elderly at age of 60 for female and 65 for male for osteoporosis by doing a disc scan. And once we diagnose them with osteoporosis, usually there's different medication we can give the patient to help to restore the bone mass, which help them to avoid any fracture. Fall. Usually, elderly can increase risk of fall. However, it's not normal also for elderly to fall. However, usually when the elderly come to the clinic, usually the nurses do a screening for a fall. When we say that the patient is increased risk of fall or he has recurrent fall, usually if the patient in 1 year has 2 falls or more. So these patients usually we need to do a full history and examination and investigation to see and assess with the cause of the fall. Sometimes the reason of the fall can be environmental, like for example, the patient did notice that there's a wire on the floor, he slipped on it, can be that the rug is not fixed really well, it could be because of the bathroom is wet. So these causes, environmental causes that we can discuss with the family and caregiver and the patient itself and give them idea how to solve this problem and how to make the patient, the environment of the patient more safe. Sometimes the causes is organic or pathological. For example, patient with diabetes, they have usually, sometimes they have nerve damage. So we need to figure out if they have any nerve damage that we need to treat to improve the walking and posture to avoid fall. Sometimes also medication side effects. As I mentioned, elderly have medication, a lot of medication, and sometimes medication can have interaction that cause dizziness and then can cause fall. So usually this multiple factorial intervention for a patient who have fall that is actually started with screening, history and examination. And the most recommendation for this patient usually to do exercise, particularly balancing, strengthening and get training, so to have stronger muscle, better balance, so to avoid falling in the future. Management of the medication, excuse me, sorry, management of the medication can be reviewed with the MD doctor that to try to avoid any drug-to-drug interaction or can avoid any medication that inappropriate to given to elderly. Home environment and modification that help to avoid falling, management of vision problem if the patient need eyeglasses or the patient need a cataract surgery, we advise him to do to try to manage the vision to try to decrease the percentage of falling. Management of foot problem on footwear. Some patients have inappropriate footwear. Some people, even the clothing, the abaya, sometimes the patient wear too long abaya that they can trip on them and fall. So these things we can advise the patient and try to do some intervention to help them not to fall in the future. A better ulcer. When we talk about the butcher ulcer, its name is butcher. That means any area with bony permanent in the body that have direct pressure or prolonged pressure can have butcher ulcer. Ulcer can be simple ulcer to severe ulcer. Simple ulcer usually management is easy. Complicated or complex ulcer, it need more management, more medication, and these ulcer can cause blood infection for the elderly and can cause more problem for health status. However, as I mentioned, the picture here in the diagram shows the bony permanent area that the patient could have basal ulcer if he lie in the bed for prolonged period. So for the patient who bedridden, usually this is, as I mentioned, this is the area of common area of basal ulcer. If he lay in his back, if he lay in the side, it can be in the hip or in a knee. So the solution usually the patient who in the bedridden and laying in the bed most of the day or all of it all day is to change the position every 2 hours. If the patient sitting in the wheelchair or in the chair, we need to change the position every 1 hour. That give them change the pressure area only, not necessarily to flip the patient all the side and the other side, only to change the pressure area. That means sometimes we put a balloon on one side to decrease the pressure on that side. Then after 2 hours, change the balloon to another side. Every 2 hours, change it. That will decrease the contact or continuous pressure. Also, airbags is really help that to decrease the pressure also. Okay, and good nutrition also. If the patient doesn't eat well, have a problem with the diet, we try to increase the protein, improve the diet to improve or to decrease the pressure also. In summary, no, there is no physical changes while aging, and they are not preventable. We cannot prevent aging. Everybody will age. I am one of them. Okay, so the advice is to stay active and healthy for active aging. So you need to change your life and lifestyle from now. If you are in 20s, in your in 30s, 40s, 50s, 60s, 70s, at any age, you need to change your lifestyle. You need to walk, be active, involve, eat healthy. So you be active all your life, and it will prevent you to having more serious diseases in the future. Control your chronic diseases like diabetes, hypertension, with the help of your primary care physician, which lead, which will, when we control the diseases better, that means will prevent most likely the other complication of these diseases. Thank you very much. Hopefully, this is Aya Qur'aniya about aging. Okay. Thank you very much. Hopefully, you have useful information from my lecture. Thank you very much for your listening. Goodbye.